So now we're going to hear from Jim Heiby. This is a critical part of the agenda to really understand from Jim what USAID has done over the last several decades, which is a great deal of work around the world, and also to understand why these 6 items are of interest. Jim has had several decades of experience working in many countries of the world, and his particular interest has been looking at quality improvement interventions and activities methods from more developed countries and seeing how they can be used in low and middle income countries. Jim?
Thank you, Sheila, and let me express my appreciation to you for agreeing to lead this very impressive assembly of expertise. And let me thank the National Academy of Sciences and the Institute of Medicine for organizing this very important meeting and bringing together such impressive expertise. And I also want to thank those of you that traveled from the frozen north for being tough enough to show up for a meeting like this. Let me begin by saying that I understand that the issues of quality and quality of healthcare is much bigger than USAID. I am going to talk a little bit about USAID, though, as a kind of test case for some of our ideas about quality, but with the understanding that the world does not revolve around USAID. If we go to the next slide. USAID has, in its central office in Washington, has been active in issues of quality improvement since about 1990. But our AID missions, about 50 or 60 of them that have health programs, have been somewhat slower to adapt this focus. But I would say in the last 10 years, we've seen a very rapid growth in the interest in quality improvement in our AID mission programs, so that I think AID is increasingly in the position as a donor to support work in quality improvement. I personally like Donna Bedian's formulation of what a health system consists of: inputs, processes, and outcomes. And in my estimation, the focus on quality improvement in the last 10 years has really focused on the neglected part of that triad, the healthcare processes. We have focused, AID has obviously provided inputs of various kinds to health programs around the world, training courses, salaries, drugs. It's also conducted a lot of evaluation surveys, so it's looked at outcomes a lot. But I would say it's only in the last 10 years or so that we've had a concerted and growing effort to ask the question, what about the healthcare processes? What about what healthcare workers actually do when they go to work? And how can that be improved? I think that's still fairly recent. I think that our interest probably was based initially on the existence of a large and growing number of process evaluations in healthcare in lower and middle income countries. I would say that they number probably in the scores, if not hundreds, with, I'm afraid, depressing consistency. They show relatively low compliance with evidence-based guidelines. So that's one very concrete set of observations that has sparked this interest at AID. Some of these evaluations, not as many of them, look beyond clinical activities to management and support activities such as health information systems or drug supplies. And those activities do not have evidence-based clinical guidelines, obviously, but they do have standard operating procedures that we hope are in some way related to evidence. And when we look at the compliance of workers with those guidelines, those management guidelines, they too are problematic. So that we have a broad-based problem with following the guidelines that have been very thoughtfully developed for healthcare, and that this has led us at AID, and I think a number of other organizations, to become increasingly interested in what can we do specifically about healthcare processes, you know, in the countries that we support. And I would say that the term of art that we use most often is quality improvement, but my argument would be that it's more accurate actually to consider this process improvement. I'm not saying that providing inputs does not affect quality at all, but that the focus and the need, I think, is overwhelmingly for attention to processes. We already know how to provide inputs, I think. So that how do we improve healthcare processes? What's the state of the art? And I would suggest that a lot of what we talk about is quality improvement activities have been around for a long time. They're a standard part of healthcare programs. Training, I think, is a very good example of that. I'm not arguing that training doesn't have an impact on quality, but it's already being done. In fact, it's probably, I think, not probably, without question, by far the largest investment in the world for improving healthcare, if you accept that as a strategy for improving healthcare. So it dwarfs everything else by a large margin. So we have traditional approaches that have always been there, like supervision and training. We have what I would call well-defined interventions, interventions that are well-defined in terms of what you do next. And I think accreditation is an example of a specific approach that is well-defined with the intent of improving quality. So that's two different types. I would add a third one that I'm going to call modern quality improvement that involves actually making changes in processes, testing changes in healthcare processes, the application of scientific method to healthcare processes. And there are a variety of approaches with different names that use that fundamental approach to quality improvement. And so we have a range of strategies available to us. So what has AID and its 50 or 60 AID missions with health programs, what have we done to improve quality? What's been the strategies that we've selected? That's one of the topics that brings us here today. As you've heard from Ashish, there are 6 areas that he listed for us that for one reason or another represent the major investments of USAID as a donor. What's the process or the thinking or the strategy behind that? Well, that's also an issue for our discussion today because there isn't one. This just happened. It wasn't planned. There's no strategy. Some missions picked one approach, others picked others. And the objective that we hope to achieve through this meeting will be to assist AID in becoming more evidence-based in its orientation towards quality improvement. And one component of that evidence base is selecting the approaches, but as I will talk about later, the evidence issues are much broader than just picking an approach. So in formal terms, what USAID has requested from the Institute of Medicine and from this committee would be your advice, first of all, in appraising the evidence for each of the major approaches that we're now spending money on. However we arrived at those approaches, I think that AID will continue in the short term to draw heavily on those approaches. There's a lot of inertia in the system. And so it's important for AID missions to have a good sense of what does the current evidence tell us about these different approaches in lower and middle income countries. There's more to the challenge to the committee than just looking at current evidence, though, that we need, I think, to address the gaps in that evidence. And as Ashish suggested, the gaps are enormous. This is not a very comprehensive evidence base that we have now. So one of the requests we have of this committee is to help us in suggesting research and evaluation that needs to be done to fill those gaps, to make our approach to quality improvement far more evidence-based than it is now. Even though the current evidence is weak, we'd like to make that stronger, and we are prepared to finance that kind of research and evaluation. And finally, beyond just fixing the gaps that address these 6 particular methodologies, I think everyone in this room understands that there's a lot more possibilities out there that are not listed in those six, and that we need a more comprehensive approach to evidence and quality improvement. And that is the long-term goal that we would hope to realize as a result of advice that comes from this meeting. So if we can go to the next slide, let me bring out a couple of themes that I have encountered consistently as we try to struggle with these issues in no particular order. But let me begin by saying that the word quality is a real problem, and that we all need some kind of general shorthand in this field, and we all use the term quality and probably overuse that term without explaining what we mean, and different people hear that word and they hear different meanings, unless what we're talking about is some specific quantitative quality indicator. So let's be careful when we have this conversation, and not rely too much on the assumption that everyone understands quality to mean the same thing. We have issues with quality on a large scale. And USAID's focus gives us that emphasis naturally, but healthcare is a big operation. This is not simply a matter of more knowledge from small-scale studies, but we really need to reach a point where the healthcare of millions of people is affected by quality improvement in a positive way. So we're asking you to formulate this issue and the response to quality improvement issues in large-scale implementation, not just small-scale studies. We will stipulate that quality improvement is not a drug trial. It's a complex social intervention. It is not intended to produce scientifically generalizable knowledge. Doesn't claim to do that. But I will make the argument that we have a lot to learn from these quality improvement experiences, and that others that did not participate in those experiences have a lot to gain from understanding what happened. It's not exactly generalization, but it is a learning benefit. So that when we talk about quality improvement, I think that it's very important for us to realize that this is an activity that creates knowledge, and that we need to manage that knowledge effectively. A very important agenda in our opinion. So in terms of time horizons, I would say that in the short term, the report that comes from this meeting, addressing the evidence for quality improvement approaches, will stimulate a much extended role among our AID missions in monitoring and measuring the outcome of quality improvement work that they support. I regret to inform you that it's quite common for our AID missions to simply pick a methodology and write a check and not monitor, not measure, and not make changes based on the data that is being generated. So that I think that the report from this committee will dramatically change the attitude of our missions in what's their role in managing support to quality improvement activities. I think that we would be very happy to see our missions increase the use of comparison groups and step wedge designs, that is, including comparisons with no intervention, no quality improvement intervention, not simply claiming that whatever happens shows that what we did was the right thing. This is something that our missions have resisted as research, but I think it's also implementation. And Another step that I think this committee can influence would be the attention to the validation of information that is derived from health programs. That these reports are self-reports from health professionals who are not scientists, and they really do merit some kind of validation. Make sure that the data that we're responding to is really accurate. So if that's the short-term agenda, I would say then the medium-term agenda would be to define the research and evaluation strategies that will address what we don't know in the medium term, so that we can make better decisions about quality improvement and strategies and use evidence to do that. And in the longer term, as I mentioned earlier, I'm a more comprehensive approach to linking quality improvement with the evidence, that this is not a matter of advocacy so much as it is of improving healthcare quality, whatever it takes. Now, I am a note of optimism that I'd like to express here is that I think that this attention to quality and improving quality based on evidence will also have the side effect of greatly strengthening health information systems, which I think have not gotten nearly the attention that they merit. And quality improvement simply is handicapped almost to the point of impossible if it doesn't have good information available in records. I think that I want to make the point also that we understand that we're asking this committee to focus on an evidence base that has a lot of gaps, and that there are a lot of negative findings of no evidence for this and weak evidence for that. And this is not as interesting or stimulating as finding something positive. But I assure you that looking candidly at the evidence and its problems is the beginning of a much more positive intervention. So that I want to emphasize the fact that negative findings that you may have on the evidence base are very much of interest to us and will be, I think, stimulate positive responses in the future. I also understand that some of the methodologies that we have listed for interest are branded. They are associated with particular developers, and that's in past meetings, some have expressed an awkwardness with dealing with branded approaches and preference for more generic approaches that don't name the names. I understand the awkwardness, but I want to point out that our AID missions make decisions based on these names. This is how money is spent. So if the report describes a methodology without naming it, I think a lot of our AID missions will miss the point. And the final slide, please. Just a few words about what we hope will result from all of this. We're looking for real change in healthcare programs. And if that change is going to happen, I would like to suggest some points that will need to be made or achieved in order for that to happen. And one of them is that whatever we say about quality improvements and quality improvement approaches, they must be designed to eliminate over time external support. We cannot have indefinite support from external agencies as the basis for quality improvement. This must be something that a health system can eventually take responsibility for itself. So institutionalization of quality improvement, I think, needs to be part of our discussion. I've already mentioned the need for quality improvement to be feasible at scale, and I mean large scale, millions of people, thousands of facilities. This is not something that is a pilot study by any stretch of the imagination. When we talk about improvement, we may need to do small-scale research, but our objective we need to keep in mind is large-scale, system-wide improvement of processes. Not only does quality improvement need to be system-wide, it also needs to be an integral, permanent part of health services. That this is not something that's a project, it's not time limited, it's not something that's solved and then you're done, that we need to approach quality improvement as really a new component of delivering health care. I would also stipulate that our vision of quality improvement is that it's carried out by the regular people, the regular providers and managers, not by specialists or consultants or external advisors. This is something that needs to be feasible as conducted by ordinary providers who are available, I think, in very large numbers, by the way, and supervised, not by external consultants, but by their own administrative levels. I would argue, maybe even a little more strongly than Ashish, that every quality improvement intervention needs to involve measurement. The term quality improvement should imply some kind of baseline measurement and then quantitative measurement of the changes that resulted from whatever the intervention was. This is a quantitative field. And I think that it's important for us now to realize that we're talking about more than just clinical care. That's important. That's where we started this field. But it really needs to apply to all of the processes in a healthcare system. And many of those are non-clinical. They involve supplies of drugs, maintaining records, human resource management, everything. All of those things eventually have an impact on the care received by patients. And quality improvement needs to include those, or needs to be suitable for addressing issues in those non-clinical areas. I will also argue that I'm not simply a blind advocate of quality improvement. I think that these quality improvement programs must be held accountable for the resources that they use and for the results that they produce. And the only way to do that I can think of is through monitoring and formal evaluations. And formal evaluations to date have been extremely scarce in this field. We need a lot more of that. We need to have a much more positive attitude towards it, I think. And finally, the knowledge gained through quality improvement activities needs to be documented. It needs to be actively shared with others because they can learn from it. And managing this knowledge, I think, is a challenge that we have only begun to think about. But to waste the knowledge that's gained from a growing field like quality improvement, I think would be a tragedy. And I think we have very strong evidence that quality improvement activities do generate knowledge that others can apply in a productive way, and that we should make capturing that knowledge part of what this report tells the world about quality improvement. Thank you very much, and with that, I'm ready for questions.
Thank you, Jim, for the background and clarification. I'm going to ask that we restrict our questions to really clarifying the task. Alex? No, go ahead.
Thank you. Excellent presentation, and it's fantastic that USAID is interested in placing a greater emphasis on evidence. I just wanted to make one point. You said, and you said that missions might not, be monitoring what they do, and they choose something and write a check and maybe not know what happens. Now, I certainly don't have nearly the breadth of experience that you do, but I'm at CDC, I'm in the malaria branch, and I work a lot with the President's Malaria Initiative, and so we work in partnership with USAID. And I think that in the countries where I've worked, the missions would say, no, we do know what's going on. And I mention this for a very specific reason, and that is that I think this is potentially part of the problem of investigating and using evidence, is that and I've seen scores and scores of presentations on what's going on. They have quarterly review meetings and so on and so on. The problem is that in these presentations, there are numbers that are put up. I almost never understand exactly what they mean, what's being measured, what's the scope. Are these the 10 health facilities where things worked well in, or is it the, the 800 facilities that they're theoretically responsible for? And so I think that one potential obstacle, as far as once we kind of figure out what the evidence is and we feel like we're ready to shift into translating that into policy and practice, I think there may be an important issue about what kind of information the missions receive about what's actually going on. And I think if the quality of that information, that monitoring and evaluation data is better, I think that could help clarify what's going on and where things aren't working well. And to be honest, from what I've seen, again, just in much fewer countries than you, I get a sense that there is a kind of anxiety among implementing partners that if they don't show successful results, they'll be penalized. And I think, anyway, that's an important dynamic as we move forward with this. But thank you very much again.
If I could respond quickly, let me say that I'm all for improving the information going to our missions, especially to senior management. We have something in the PEPFAR program called a COP, a Country Operational Plan, that summarizes accomplishments and plans for the future. And these are monster reports, some of them 1,000 pages long, and we've had an unfortunate intern spend some time reviewing those, looking for quality improvement. And what he found in a small sample was isolated references to quality or quality improvement or quality of care with no description, no programmatic information, no data, just we're doing it. So that at the senior management levels of the agency, USAID is not engaged in actively managing and evaluating its work in quality improvement. I would add, though, that I think that the evidence issue includes not just results, but how. What did you do? How did you do that? So that I think we can certainly agree that there's a lot of work to be done.
Okay, I'm being urged to keep to the time limits here. So we're going to take a break and then come back and we'll get as many questions as we can into the following session. So if you could please return at 10:30, thank you.